You were tuned in to The Local Lens, the podcast from the Powell County Health Department in Kentucky, Rio, where we go inside our community's experience with the drug epidemic.
There's nothing worse than trying to ask somebody that has a clouded mind, and I don't care whether it's substances or depression or whatever. If their mind is clouded, it's hard to get them to see something different, no matter what you're trying to get them to see. So sometimes it takes that ability to make that happen. And if they come in, sometimes people will come in with one thing in mind, but they walk out with an entirely different perspective because of the services and the people that are motivated here that make a difference.
It takes the amount of trust between the patient and the physician or whoever's doing their treatment on where they go with the treatment, on how far they advance with it. So everybody here is very willing, very understanding. We've all worked in it for a while as to what's going on with them. They may not realize that we know when they walk in, what's going on outside of what drugs they use, but different things, because we've worked in it for so long. We know that there's some amount of depression there. We know that there's some amount of anxiety there, and that we have the resources to help you. If you're coming here and just want to come in and get medication and turn around and leave, you're missing out on all these services that we offer, and things that can help you, but they have to want the help to be able to utilize the service.
Thank you for joining us for this episode of The Local Lens. Our show is coming to you from Stanton, Kentucky, a small town nestled at the foothills of Appalachia. Our region has been wrestling with addiction for well over 2 decades now. And on this episode, we are going into one of the more well-rounded responses to this overdose crisis that I've seen yet. We're in a healthcare center that offers pretty much everything you could want a place to offer, all under one roof. They started off only offering counseling, but then they realized they had to start offering more services if they were going to be fully effective. Let's go in and get into the episode. My name is Nate Brooks. Thank you once again for tuning in to The Local Lens. These are our people using our voices, telling our stories, because no one sees it like we do.
Okay, I'm Tracy Fryman, owner of Eastern Kentucky Recovery and also Central Kentucky Recovery, based out of Cynthiana. I am an RN by profession. I started my RN career with an inpatient facility. At the time, it was called Stoner Creek in Paris. Been working with addiction for probably about 11 years now.
So I'm Scott Seitz. I'm a family practice nurse practitioner. I've been practicing a little over 20 years as a nurse practitioner. I've been in the industry for 35 years, working with addictions inside or around addictions for the last 16 years.
You may remember Scott Seitz from one of our early episodes from this show. Now, this guy, he was one of my best teachers when I was just getting into all of this kind of work. So I am thrilled to be having another chance to talk with him on an episode.
I joined Eastern Kentucky Recovery and eventually Central Kentucky Recovery to bring in the primary care component and to treat substance abuse because we believe in the holistic approach. And we can make a difference one-on-one, but we'll make a difference exponentially when we work together.
When I started with this, there was not many services. It was kind of on the cusp of the opioid epidemic. So at that time, there was no counseling or anything in the area. So that's what got me started in starting to provide that type of service.
So when she was in that job, she had quite a bit of hands-on experience with people in the early stages of recovery.
It was primarily a detox. We also dealt with mental health on that unit, and we were trying to discharge these patients out, and there was no outpatient services in that area. It was the point that, what are we going to do with these patients? They have no treatment after they leave us.
So she stepped up and did a pretty challenging and incredible thing. She went and started this place that could offer the treatment necessary after those initial stages. So that is where we are right now, is the place that she started. It is Eastern Kentucky Recovery. She also has Central Kentucky Recovery. And this place offers so much stuff under its one roof. They started off, like we mentioned earlier, with counseling services, and then they grew into using medically assisted treatment, which is basically using medicine to help people with recovery. They also offer several other mental health services, and now they even offer primary care. So all of this stuff can get really confusing pretty quickly to me. So let's look and see what this place offers in its context with all the other stuff in the area. What is the difference between this place and something like ARC, something like an inpatient, like a rehab center?
Well, the first thing is you go home after you get seen here, where in any of the inpatient centers, you're there for a week, 2 weeks, 3 weeks, 4 weeks, 6 months, whatever the program is. So you get to go home. Then you also get to take this place with you, because we're here 5 days a week. We have access on the weekends if needed. We are here on one Saturday a month trying to help patients that need to be seen on a weekend. But you can take us with you because we're available. It doesn't end. You might be finished with addiction services, but there's still counseling services here. There's still primary care services here. There's also education. A couple of things that we've just started doing is DUI classes and parenting classes and things like that. So there are other services that we can help. And then we have connectors to all kinds of different programs. So this facility, not that inpatient facilities can't offer some of that, but they're focused on inpatient acute needs. And then when the acute stuff is over, they usually hand off to someplace else.
They're like a turning point more.
Correct.
Yeah. Okay.
And we are a facility that can help in that transition. When it's time for them to go home, but they still need treatment, and I think we talked before, nothing can happen in the first 30 days. And that's what a lot of insurance covers, is a 30-day program, and then you're done. And then you got to figure out how to make the rest of that happen. And you just can't make those changes in 30 days. But you can start there. And then something like an ARC or Shepherd Shelter or any of the other services that are out there, they can refer to us, and we can continue what they've started and help the patient build on those ideas and continue to make those changes in their lives.
So this place does catch people as they are coming out of their initial in-person inpatient programs, but it can also play a big role in preventing people from getting to the point where they need to go to an inpatient treatment facility in the first place.
There's some patients that we've had in this program that care for their mother or their grandmother. They may have handicapped children that they're having to deal with, babysitting issues, people to care for their children if they go inpatient. This is kind of a way to help them that way, to, I guess, allow them a little bit more freedom to be able to maintain. Some of them can get a job at night, work a second shift at this program during the day. So that's what we felt was a step to keep them from having to go inpatient.
So in this episode, we're going to be focusing more on this group's general approach to healthcare. But this group does use medically assisted treatment, which is somewhat of a controversial topic. Now, medically assisted treatment, or MAT therapy, as you'll hear it called quite a bit today, is really just a way to use medicine to fill the space in the brain that drugs would normally go to fill, that heroin would normally fill. So basically, it's a regulated way to silence the crave of drugs. We're not going to be focusing too much on this topic today, but you will hear the treatment mentioned quite a bit. We will be having a deeper dive into MAT therapy, though, in an upcoming episode, so stay tuned for that if you're interested.
When we looked at it, like the counseling, we give them the medications in inpatient, but then there was, like I said, there was nothing in the area. So we started basically with the counseling, and then we were looking for other ways to treat. Counseling sometimes doesn't cure all. It's not a cure-all. And they only get out of it what they put into it. If they're going to sit and talk to you honestly about what's going on, then they're going to get a good response from it. If they're not, then you have to look for other resources and other ways to assist that patient.
So there is an incredible quote that we have from Scott's first episode that we use in everything that we show people, that it's the mind, body, and spirit coming together for this. Counseling seems to be addressing the mind part of it, possibly get into the spirit at some point if the patient takes it that way.
Right.
So you wanted to introduce some more of like the body part of it, I guess? Is that?
We try to look at things in a holistic manner because, even though they're doing the counseling and we can offer the medication as another source of treatment, there's a wraparound effect with that, because once you treat the symptoms, you uncover things that were there that probably initially started all this rolling process, whether it be depression, anxiety, domestic violence, abuse of any kind. So there's other things underlying in that. So it's a whole effect. And they have to be open to that to receive the treatment for all of it, not just getting my meds and going. You have to be open to the counseling, even the case management, different things like that. You have to be open to all of it.
For any given patient that comes in, how often, like over the course of a month, let's say, how often would you see just any given patient?
Weekly.
Okay. They come in once every week for all their needs?
That is determined by the physician on how long they're weekly.
Okay.
Typically, if a new patient comes in, they're weekly. They will see the physician. They will see our psychiatrist we have on staff. They have to see her at least once. And then they do counseling, drug screens weekly.
So one of the coolest things about this, just immediately, you all wear it on your sleeves here. This is like a one-stop shop for a lot of things. And you even have the primary care. Yeah,
we Scott started with us in August. There's a few other things that we do too that I haven't touched on, but yeah, we've incorporated the primary care. Scott came on board with us in August because we wanted to do an even bigger wraparound effect with some of the patients. A lot of them, most of them or several of them have hepatitis C. So that's an issue that we address whenever we do our blood work. We have previously referred to outsource that treatment. Scott came on board with us in August to help us get all this under control. Even any other medical issues they may have, he can address when they see him, and also with the Hep C. So any underlying issues, he's been able to help with that.
So let's talk about Hep C for a minute then. So what happens when somebody has Hep C? What is the issue with this?
Well, it affects a lot of things. Really, well, the worst I've seen, I've had a patient come in and he is, when we do this screen, his urine is almost black. He was in liver failure and stuff like that. So getting that treatment and stuff like that, it's different things that happens. It affects everything in the system.
Truly, it's soup to nuts.
Yeah.
Somebody can have Hep C infection and have zero symptoms, zero illness, all the way to being deathly ill.
Okay.
So we see that across the spectrum.
Some may not even know that they have Hep C until you do the blood work, and it pops up. We've seen some with hepatitis B.
Okay. Been
able to catch that on some of them.
What are the differences between C and B?
There's 3 different kinds.
Is the third one A?
Yes.
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 Very good. So A is typically oral. So that's the acute illness. That's the kind of thing you can get from food and stuff. And then there's B and C. And B is tends to be acute. You tend to be sick quickly. Where C can be manifested over a long period of time.
Basically, once Hep C is in your body, you're opening up your body for just a whole slew of mishaps going on inside of you. One of the big draws of having a syringe exchange program is that they lower the risk of spreading hepatitis C. How much burden does a case of Hep C place onto a small clinic like this?
That varies.
Yeah,
I guess it depends.
Yeah, I haven't noticed that it's put any kind of burden on us.
Okay.
For that matter, we can coordinate up until now with Scott here, but we coordinate with whoever they follow up with. We also communicate with the health department and stuff so that we can coordinate the treatment. The key is, with these patients, once they find out, is making sure they do their follow-up appointments with that physician. Some of them won't, so then you're constantly saying you need to be treated, Now that we have the primary care services here, we can say, you need to go check with Scott, or see if they're already set up with him and we address it, then he can treat it. And we don't have to wonder if they are getting the treatment or not. Some of them won't show.
But if you look at somebody holistically, there's a lot of reasons why they might not show up at an appointment. Mm-hmm. So by us coming and having everything in one place, it makes it easier. Plus, as we talked before, Nate, there's a soft handoff. When you have somebody that you can go down the hall and say, hey, let me introduce you to this person, they tend to be more apt to come back than handing them a card saying, follow up with this person, and not know where that office is or not know anybody there. There's always some stigma involved with addiction, and people are worried about that, and rightfully so, because sometimes there is a judgmental part that they have to deal with out there, and we don't do that. So it makes it easier for people to address everything. And as we've talked before, the mind, body, spirit, you can't treat just one thing. You have to treat all of it to make somebody whole.
The stigmatism with some of it depends on where you are. That's a major setback. Like you mentioned before with the patients, a lot of them will not go to a primary care doctor. They'll come and say, I'll say, because when I go there, they treat me like I'm dirt and I won't go. So I hear that a lot in Cynthiana too. But since he's on board, he's seen some of our MAT patients now. So that seems to be improving. It's just a matter of the resources and where they feel comfortable going, because they won't go if they're not comfortable there.
And just kind of an anecdotal assessment in the 3 months I've been here, seeing the patients that are already involved in MAT therapy, they come over and I talk to them about their health. We're doing labs and the rest of it. Roughly 70% of the patients that I've seen from that side have chronic health conditions that need to be treated, that have had no treatment. I've found rheumatoid arthritis, I've found sleep apnea, I have found hypertension, I've found diabetes. In just that little short period of time, in just that small population, that's a lot, 70%.
That is a lot. And then for the gateway on their treatment being just a worry about perceptions, which comes from both sides of it. It's both maybe an unreasonable worry in some situations that the patients themselves have, but also maybe an unreasonable stigma or like avoidance, I guess you could say, from like the provider side of it. So, and you were mentioning about that earlier with like same thing with the counseling, where they have to be willing to receive
they have to be open
as
to
well.
it.
Yeah.
They have to be willing to open up about certain things that's going on. But that takes a relationship between the counselor and the patient. When you first see somebody, they're not going to just spill the beans, So it takes consistency. And that's why when they're with us, they're weekly for a while when they first start our program. Because granted, we can monitor their progress, monitor their drug screens. They see the counselor more often. They do have the option to go monthly here. But that's down the road a little bit. They have to be stable in where they are on their medications with counseling, job, and stuff like that before they're able to move to that monthly aspect.
But what keeps people coming back the second time after the first time here? Why couldn't they just also not come to this appointment here?
I would say, and I'm just going to be frank about it, for the medication. Until they're involved with the counselors and in the other kind of treatment, they come back for the medication. We can do same-day appointments here. Now our psychiatrist is here just about every day. Scott is now certified to do the buprenorphine products, so he can see patients on a daily basis. And I think once they get started and they're here, then they develop a relationship with the staff, with everybody, and then they feel more comfortable once they're here. And that gives them the opportunity to open up about different things that's going on with them.
I get to see them on the rehab side periodically as well. And so when the guys come in to the rehab, a lot of times they're still high. And you're trying to get them to understand that rehab is the answer. Sometimes they're placed there because they have no choice. So their mind is not, I want to do this, but they have no choice. Get somebody to understand that. And then you get them through the detox or you get them through the withdrawal or whatever. Now I'm mad because I don't like what I did. I don't like having this problem. I don't know anybody in this facility. There's a lot of dynamics that happen with that initial, okay, I've got to get treatment.
Mm-hmm.
So,
and it doesn't matter what your intentions are as a provider then too. Like
nope.
Somebody's not taking the time to, like, they don't know who you are, Tracy.
Right. Correct.
When they see your face.
Right.
They just see, oh, this is another person.
Right.
So that takes time, I imagine.
And that's another reason why, when you can offer as many services as we do, in the variety that we do, you gain that trust a whole lot faster. Oh, he's working with her, she's working with him, she's working with her, those kinds of things, and they're all together, and they're all doing this. Wow, maybe I do need to change the way I think, and maybe I can do that a little bit faster.
So for the provider here, it is a struggle between the short-term goal of trying to give the people exactly what they need versus the long-term goal of wanting them to come back long enough so that the patient starts to want what they actually need.
As long as they're getting their way, they're fine. If you put something, say, no, you have to do it this way, you have to be here at this time, you start pushing the gamut, then that's when they get upset. So we're going to have some that'll do that. You have to be here on this day to do your counseling, blah, 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 blah. If they don't get what they want, then they tend to go somewhere else. And unfortunately, there's a lot of MAT clinics around, so they can hop, skip, and jump to them.
So this is where these MAT clinics get some pushback. This is where medically assisted treatment is criticized, because on the surface, it does look a bit like the pill mills that did a lot to cause these problems of addiction in our area in the first place several years ago. But this is one of those instances where you have to trust that the medical field has generally learned from its mistakes and has improved for our services and has responded to the needs of our people. And I believe that it has. So here's a quote from our previous episode with Brenda Drennan, the nurse practitioner from Shepherd Shelter Ross Rehab, talking about how she sees medically assisted treatment as good and useful.
I look at Vivitrol, I used it in primary care. I look at it as a tool to help you take that alcohol and opiate off the table so that you can concentrate on your treatment, which be therapy or whatever. It's not enough by itself. It's not a one-shot wonder. It doesn't do anything other than block the drug. That's what it does. But once we've blocked that drug, then you can open your mind up to outpatient therapy, inpatient therapy, whatever it's going to take to keep you sober and get into that normal life. And then once it becomes habit, then you don't need the shot anymore later on. But it's a tool, and that's all it is.
Not a crutch.
Should not be.
Yeah.
If they expect it just to fix it, it's not going to. There's not one thing that fixes addiction.
So now we're going to jump back to Scott Seitz and hear how he's using this stuff as well.
Let's look at MAT therapy. Medication-assisted treatment is to help you manage a problem, okay? And there's various forms of management. Some people will take Suboxone, for instance, just so they're not using heroin. Now, it's a safety, because the likelihood of overdosing is pretty slim, so there's that aspect of it. Some people will use Suboxone or Vivitrol or any of the other treatments as a bridge to get to the next level of sobriety so that they can come off of those meds and live a new, changed life. Other people need treatment for a long period of time for various reasons. So it depends on what the motive is when they come through the door. If it's, I can't get any more heroin and I need to have something so I don't go into withdrawals, then they want buprenorphine products. And they might not come back.
So if you're looking at a general family practice type of medical setting, you can pretty safely assume that all of the patients there just want to be healthy. So if your medical provider suggests to you that you should get this procedure done, oh, your foot is broken, you should get an x-ray, and we should put a cast on your foot so it heals, you're really not going to fight back from that. But this is different because of how addiction changes your process of thinking. So people don't necessarily want to get healthy. or at least they can't tell that they want to get healthy yet.
And as a provider, if the motive is I want Suboxone, say, just because I can't get heroin, do I say no to that? No, not necessarily, because what I'm trying to do is make a relationship. And if I bring them back on a weekly basis and they see me and they see what sobriety can give them, then maybe I can sell the other services. Then maybe I can sell this as a health issue now. Mm-hmm. There's nothing worse than trying to ask somebody that has a clouded mind, and I don't care whether it's substances or depression or whatever. If their mind is clouded, it's hard to get them to see something different, no matter what you're trying to get them to see. Mm-hmm. So sometimes it takes that ability to make that happen. Mm-hmm. And if they come in, sometimes people will come in with one thing in mind, but they walk out with an entirely different perspective because of the services and the people that are motivated here that make a difference.
Mm-hmm. It takes the amount of trust between the patient and the physician or whoever's doing their treatment on where they go with the treatment, on how far they advance with it. So everybody here is very willing, very understanding. We've all worked in it for a while as to what's going on with them. They may not realize that we know when they walk in, what's going on outside of what drugs they use, but different things, because we worked in it for so long. We know that there's some amount of depression there. We know that there's some amount of anxiety there, and that we have the resources to help you. If you're coming here and just want to come in and get medication and turn around and leave, you're missing out on all these services that we offer, and things that can help you, but they have to want the help to be able to utilize the service.
It's not just a medical problem. And so frequently, medicine says, let's fix it medically. Mm-hmm. And it's not. We have to treat it holistically, mm-hmm. which is, again, another reason why I'm here at this clinic, because that's what we're trying to do. And I think we're going to see a bigger success rate at people overcoming that problem. We don't do that. We don't fix those issues. The patient does that. We just help guide them. And sometimes it takes a medicine to help guide them through that. But us writing a prescription doesn't fix the problem. It's them taking the prescription and working through whatever it is. I can write somebody insulin, but if they're eating McDonald's 14 times a day or some kind of other fast food 14 times a day, the insulin's not going to fix it.
Who's doing that?
But I mean, it
14
happens
times a week.
Maybe. Yeah. But still, you got to look at everything that's involved. That insulin's not going to fix that problem if that diet is not going to fix it. And so neither is Suboxone or neither is Vivitrol or other. There's so much more.
Once the addiction is stabilized with medicine, then the other stuff starts to come about. The mental health side of this is something that needs to be looked at too quite a bit. Mm-hmm. It's like you said, you give them the medicine, but there's other underlying issues there that started this. So that's where we come in at, the holistic approach.
Well, that's all the time that we have available today. Thank you all for tuning in and listening to this week's episode of The Local Lens with Scott Seitz and Tracy Fryman from Eastern Kentucky Recovery and Central Kentucky Recovery. I know that we might have gotten a little technical about some things today, and I want to tell you with some assurance that that is not near the most technical we can get. In fact, our next episode is going to be a deep dive into medically assisted treatment. We're going to be having Scott and Tracy back on that episode as well. We're going to be joined by Miss Brenda Drennan, who we heard from a little bit more in this episode as well. All right, so I am actually running out of time now, so I would like to thank Scott and Tracy for joining our show again today. It was a pleasure having you guys on. I would also like to thank WSKV for broadcasting our show, and also a big thanks to the Powell County Health Department for starting the show last year, and Kentucky Rio for helping us keep it going. And thank you, listener, for thinking this is interesting. Please let us know online if you are listening. This is The Local Lens. These are our people using our voices, telling our stories, because no one sees it like we do.